5, 4,
Shamshul, so you start.
3, 2, 1. We are live now.
Yes.
Hi, good evening, everybody. Very
Yes.
good evening from ASAMI, India. I really congratulate everybody from Telangana state. So that this is the very first initiative from our dream project, budding Ilizarov surgeons. It was really a dream that Akansha has made through with our respected faculty. And it's great to see all the delegates from Telangana and Delhi and even Bangladesh. So with this, without wasting time, I request Akansha to start the webinar.
Thank you, sir. Good evening, seniors, colleagues, and all the postgraduate students who have joined with us tonight. So, we would be starting the Budding Ilizarov Surgeons Telangana State chapter for Ilizarov basics for the purpose of involving a curriculum of understanding the very basics for postgraduate students and senior residents alike who are interested in using Ilizarov as a means to go forward and get to learn a little bit more on a daily basis while observing and from senior faculty who have learned the intricacies of it traveling far and wide. So with that, I would like to start the very first webinar, and I would like to introduce the faculty tonight before that, and before we start with the talks. So first I would like to share my screen, and so is my screen visible to everybody?
Yes. Yes.
Yes, yes.
Okay.
Yes, yes. Okay.
So introduce Srinivas Reddy first. His talk will be.
Okay, sir. Fine, sir.
Hello, Prasad. Hi.
Okay, sir. I'll start with Srinivas, sir. So,
Or you can do one more thing. You finish your talk, and then when Srinivas Reddy's talk is there, you introduce him. And just before my talk, you introduce me.
sure, sir. Okay.
Just you can mention the names. What is the total program today? Name.
Okay, sir.
And then you start your talk.
Okay, sir. So I'll just tell everyone our program today involves going about a little bit on the history of Ilizarov with a presentation that I'll be giving for 5 minutes, followed by which Srinivas Reddy sir will be taking a talk on the basic instrumentation of Ilizarov. And following that, if anyone has doubts, we would answer. Eventually, we would progress and we would go ahead and have interactive case discussions. So Prasad sir will be kicking that off by explaining regarding the 2 proximal tibia cases that he would like to discuss with us. And then Srinivas Reddy sir will be speaking about a case wherein he has used fibular bone transport as well. So with that, I'll just introduce myself before starting my talk. I am Dr. Akansha Sinha. I am from Hyderabad, and I'm an assistant professor in orthopedics in Osmania Medical College and Hospital. So just share my screen.
Please go full screen.
Yes, sir. Is it visible, sir?
Yeah.
Yeah.
Make
Clear.
it full screen.
Make it full screen.
Sir, it is on slideshow, sir. Is it visible?
No, it's not full screen actually.
Not full screen. It is visible, but make it full screen.
So is it okay now, sir?
No.
No.
Not at
With
full
that, I'll make it open the PowerPoint in the background and then share screen again.
Okay, fine.
Now open the PowerPoint in the background, then go share screen, then select the PPT, not the whole window. Okay.
Yes, sir. Okay. Is it visible, sir, my screen now?
No, you are visible.
Okay, sorry. Sorry about the technical glitch.
I think it is coming.
but I'm not able to see it. Yeah.
Yes,
So
now it's
visible
okay.
now,
Yes.
But
Perfect,
yeah,
perfect.
now
Go ahead.
it's perfect.
Done. Go
Perfect.
ahead.
Okay, fine, sir. So thank you so much, everybody, for listening in first. So the layout of the history would be, I would be starting the journey of the ring fixator, the circular ring fixator from the very beginning, in fact, even before the beginning. And I would go ahead and express what all I have learned about the Ilizarov method that developed eventually from that beyond the World War II, and how the awareness spread and how we have been transcending its legacy beyond. So 377 BC, Hippocrates was the one who started using wooden rods from a cornel tree and spanned it in order to fix a tibia fracture to begin with. Eventually, John Francois Maleny, he actually used a clamp, which was like an external fixator for the olecranon. Eventually, in the United States, people started using the clamp for the purpose of stabilization of a femur fracture. So Clayton Parkhill did that. Then Albin Lambert used, just before pre-World War II, something like an external fixation device that would span the fracture and allow dressings to be done through the pins that were inserted on the femur. So in United States, there was a general surgeon by the name Joseph Bittner, who actually used circular rings with transfixion wires, and they all had hinges around it, which would, whenever they would tighten and the diameter would increase, the tension would increase, and therefore the beginning of the circular external fixator was attributed to Joseph Bittner. Eventually, the Europeans and the people from the Russia in around 1938, within a span of 3 years, like Petrovsky, Gottschalk, and Kalberg, they actually utilized his principles and used it partly to treat the injured in the World War II. And beyond that, around World War II time, when Dr. Gabriel Abramovich Ilizarov finished his education, he started using that technique he started learning a little bit about it when he was posted in Kurgan, that is Western Siberia. So he was actually posted as a general practitioner from 1944 onwards. And eventually he was researching so much on bone regeneration. Within a span of 10 years, he was made the chief surgeon at Kurgan Regional Hospital, using his techniques of bone regeneration, using the principle of tension stresses in the Kurgan Regional Hospital. So his fame rose when, after a span of 20 years, when there was this high jumper who actually fell down during his bike ride in 1965, and he underwent a lot of procedures for his tibia, but it ended up with a non-union. So what Dr. Ilizarov did is that he used 15 surgeries to eventually correct it and free him from any form of infection. So later on in 1968, he again went back and he took part in the Olympics, and he won laurels for Russia. So this is where the publicity of the Ilizarov through a very high profile jumper started. More so, the method was the one that was publicized. So Carlo Mori, he actually underwent infected non-union. He had infected non-union tibia by virtue of having a skiing accident in 1961, and he was left with a pseudoarthrosis. He had an equinovarus deformity, and eventually it was shot. So what Dr. Ilizarov did is that he distracted it by using his principle of distraction osteogenesis in 1980. So now this is 35 years after he has joined in Western Siberia, and he managed to gain 2 centimeters and the pseudoarthrosis united. So during this time, actually, there was a doctor from Italy who was doing his research on distraction osteogenesis, who was around in Russia. His name was Dr. Renato Spinelli. And what he did is that he publicized this method of union and mobilization of Dr. Ilizarov when he went back to Italy. So eventually his professor called Dr. Ilizarov in 1981 to give a talk at the AO Italy Club in Bellagio. So where he had presented 3 lectures. So in and around this time, the East German newspapers would call him as the Siberian Doctor of Miracles, where he would treat infected non-unions, and he would also gain length in a patient who would just be around 21 centimeters long, suffering from achondroplasia. So what happened is that when he was invited in 1981 all the way from Russia to Italy at Lecco, he actually gave a talk on the treatment of open fractures and the talk on treatment of post-traumatic osteomyelitis and eventually bone regeneration. So this was attended by 200 people from all over Europe, mostly around Italy, Austria, and Switzerland. So what the Italians did is that they visited Dr. Ilizarov in Kurgan a year later, and they started propagating the Ilizarov method more so. So Dr. Maurizio Catagni, he spread this method all over Europe, and people would come down to Italy and learn from him what all he had imbibed from Dr. Ilizarov. Eventually, the Central Institution of Traumatology and Orthopedics in Leningrad was made. So once Dr. Ilizarov gained popularity through his method and through his scientific knowledge on bone regeneration through distraction osteogenesis, in 1982, Kurgan Research Institute for Experimental and Clinical Orthopedics and Traumatology was initiated, and it expanded with 1,000 beds and 12 operation theaters, which was a very big feat that the institute had achieved. The time between 1983 and 1985 was the crunch time where Dr. Ilizarov propagated his ideologies of and principles of Ilizarov across United States, Europe, and also Russia all around. So Dr. Rohr Paley visited him in 1985 from United States, and he went back to the United States and started instituting his principles in Toronto and Baltimore both. So at that time, when Dr. Victor H. Frankl, who was the Center for Joint Diseases chief, called Dr. Ilizarov in 1987 and 1988, which was a very big international conference that was held on his principles of tension stresses. So 3 talks and 3 articles likewise were published in his Journal of Clinical Orthopedics and Research. And his applications for genesis and growth of tissues was even more publicized to the modern world. So this master of distraction osteogenesis was given the Lenin Award in 1979. He was called the hero of the socialist labor, and a stamp was named in his honor. And he was also named to the Russian Academy of Science. Eventually, the perspective that he had spread across the entire world by the end of 1990. And his applications of distraction osteogenesis can be seen in the humble tibia frame or the hybrid one, or even as advanced as the hexapod that we are using today. So in his name, so he basically expired in 1992, but he left behind a legacy in honor of which his bust and the Ilizarov frame, along with offshoots of the tree, which symbolize bone growth and distraction osteogenesis, were instituted. And he started off as the son of a Polish farmer who couldn't even get education till he was 11 years of age. But today, the institute at Kurgan is named in his honor as the Russian Ilizarov Scientific Center for Restorative Traumatology and Orthopedics, where surgeons from all over the world get training and give more meaning to the concept of life is mobility and mobility is life. So these are my references. Thank you, everybody, for listening in.
Thanks, Akansha, for a wonderful introduction. So the main motive of budding Ilizarov surgeons that while we're doing ASAMI India or masterclass, only the seniors and the masters are talking. Here we get to see that our young surgeons, young ASAMI members are giving wonderful presentations. So with this, I request everybody, all the states, to do their BIS webinars and interactive sessions. And now I request Akansha to move ahead for further talks.
Even
Yes,
we learned the new things in history. Thank you.
Right, sir. Perfect.
Okay.
Good.
we'll move on with our presentation, and we are right on schedule. So we will start a topic that is very fundamental to any orthopedic trainee or surgical or orthopedic surgery resident in the field of Ilizarov as a budding one. And that is the very fundamentals of understanding the apparatus, the machine with which we work and we make wonders, the machine which helps us make wonders and eventually helps us throw offshoots of bone and gives meaning to the word life is mobility and mobility is life. So with that, I would like to introduce the next speaker, and that is Dr. Srinivas Reddy, sir. So is my screen visible, sir?
Yeah, not visible.
1 second.
Go full screen.
Yeah. Is it visible, sir, now?
Yes, right now.
Yeah.
Perfect.
So Dr. Srinivas Reddy, sir, is a professor of orthopedics at Pratima Institute of Medical Sciences in Karimnagar here in Telangana, which is a little about 200 kilometers from Hyderabad. So he has studied in Kakatiya Medical College from 1985 to 1991. And eventually he graduated from the same institute by doing his master's in orthopedics. And he has done his fellowship under Dr. Milind Chaudhary in 1996 in Akola, wherein these are his old pictures. And eventually he went about and did his training under Dr. Maurizio Catagni, who propagated the institution of the Ilizarov method across Europe in 2000. These are the pictures of Srinivas sir with Catagni sir, and eventually with Dr.
We are not seeing Akansha.
Sir?
Slide is not moving.
It's not moving.
Slide is not moving.
You're on the first slide only.
Is that the first slide only?
Just a minute. Sir, is the screen visible, sir?
Screen is visible. Go to the next slide.
I'm on the next slide, sir.
No, you are on the first slide.
You can go off full screen.
Yes, sir. Just a minute. Sir. I'll just. So, is my screen visible, sir?
Not
Yeah,
it.
you are.
Not
You are
it.
Is my second slide visible, sir?
No, not it.
We cannot see your screen.
Oh, just a minute. So, is my second
Yeah.
slide visible?
Yes.
Yes.
Second slide visible.
So, sir actually completed his graduation in medicine from Kakatiya Medical College. He went on to pursue his master's there, and he got his training in India at Akola district under Dr. Milind Chaudhary, sir. And he eventually went in 2000 to get trained at Lecco General Hospital in Italy. These are his pictures with Dr. Maurizio Catagni and with Dr. Robert Catania in Milan, Italy. So, sir has been awarded prestigious award, that is the Vigdeshwar Gold Medal Award for the best podium presentation in the AP chapter of IOA in 2003. And sir is very actively involved in training young minds in the field of Ilizarov and traumatology. So, sir has conducted a lot of workshops. He's got a lot of publications, and he's a guest lecturer in many national and international conferences. And eventually, sir has operated on more than 2,000 Ilizarov cases till date. So, this is a picture of sir with Dr. Maurizio Catagni in 2017 at Portugal. And I would now like Dr. Srinivas sir to please start his talk on the basics. Thank you.
Thank you, Akansha, for a great introduction. I'll share my screen. Yes. Share. One minute. Share screen. 1 minute. Right. Share screen. Share screen. Share. Is it okay?
Screen is not visible. You are
Screen
visible.
is not visible. Wait. Open system preferences. Okay, 1 minute. Okay. Is it
Sir, you have to open the screen in the background, whatever screen you wish to share.
it
Like
is open. It is open. It is open. Share screen. Screen. 1 minute. It is opened on my laptop.
Yes, sir.
But
So basically, from the icon share screen, you have to go back and the dialog box opens up. You can just share, you can just select the screen you wish to share.
it is there. Huh? It is there. It is opened on my laptop.
Yes, sir.
It is open on my laptop.
Yes, it has to open through Google, through Zoom, sir. So once you click on share screen, a small icon of that appears on the main screen. You have to just select that and it starts connecting to the Zoom operating system.
Go to Zoom screen
Mm-hmm.
and there will be a green button in the middle.
Yeah, I know that. I know that. But
So you can mail to Akansha or me. We'll run the slide if.
okay, okay, right. It will be very easy, but right now I don't know. Wow.
No, sure, sir.
Can I show one, sir? I'll just show. So once I click on share screen, sir.
1 minute.
Yeah.
1 minute. One way. This is a share screen is there.
Yeah.
Green button.
On that.
Yeah, green button is there.
Click on that
Yes.
and select the
Yes.
PPT. Select the PPT.
So a small icon of the opened slide show is there on the dialog box, sir. You just have to.
I have to do it. Share sound, share. Open system preferences. Okay. So,
Hello, sir. Can I know what are you looking at the front of your screen visible?
yeah, it is visible. It is there. It is on my laptop. It is very clear. There's.
Just wanted to know that after clicking on share screen, which screen is visible to you?
It is a share screen. It is the presentation is there. It is actually.
Yes, just you have to click on the screen and click on the share button down right below.
Slideshow. Share button is not here. Icon of your presentation. Click share.
Sir, I've shared my email. You can share the PPT to my email. I'll just share for you.
Okay, okay. I'll do that. I'll do that.
Or with your mobile, you open a video call with Akansha or someone else who is guiding you.
Yes.
And then they will guide you what is to be done. Make a video call.
Yes, yes. Wait.
Just mail to me, sir, in the meantime.
No.
In the meantime, what we can do, can we share Prasad sir's PPT first?
Sir, it will take a short while to.
Ask him to mail to me. I'll share for him.
Yeah, yes, sir. He's just emailing it to me, sir. I'll just.
That's fine. That's fine.
So, in the meantime, Prasad, sir, can we please have your presentation, sir?
You must introduce him first.
Yes, sir. Okay, sir. I'll just share my screen, sir. So,
Please go full screen.
yeah, just a moment, sir. So, is my full screen visible, sir?
Yes, yes.
Okay. So, Prasad sir is a national senior ASAMI faculty, and he's the he's the founder of Srujan Accident and Ortho Care at Khammam in Telangana, and sir has also studied in Kakatiya Medical College from 1982 to 1987. Sir has done his D-Ortho from JN Medical College in Belgaum, Karnataka in 1989. And a year later, he started this hospital, which is a tertiary care center for Khammam at in Telangana. And sir has done a fellowship under Dr. Shwetsov in 1997, who is the first generation disciple of Dr. Ilizarov. And he went on to do his advanced training in Ilizarov methodology under Dr. Maurizio Catagni at the same Lecco General Hospital, Italy. So these are the pictures with Dr. Catagni in Italy when sir was undergoing training. And this is with Dr. John Herzenberg when he was undergoing his Baltimore limb deformity correction. And we can see here Vasu sir and our current president Rajat sir as well, along with Dr. Herzenberg and Dr. Prasad sir. So in 2006, he underwent training under Dr. Paley, sir, and he underwent an observership at the Sinha Hospital in Baltimore, which is a world-renowned center for regional, it's a regional institute for advanced orthopedics, so to say. And sir has been an observer under Dr. Professor Gamil Ahmad Hosni in 2008 in Cairo, Egypt, from whom we had the masterclass in the last ASAMI session. Sir is an ex-EC member of ASAMI, and sir is extremely interested in guiding young minds, and he has taken countless lectures on Ilizarov and its methodology through workshops and lectures here in Telangana. Sir was actually our ex-Telangana Orthopaedic Surgeons Association president. So he has conducted a lot of workshops. He's presented many papers, guest lectures, and he's a senior ASAMI member. And we are very delighted to have you, sir, here with us tonight. Thank you, sir. I'll stop sharing my screen and you can start.
Thank you, Akansha, for the elaborate introduction. Actually, there are a lot of cases with me, but instead of those two, I felt that instead of would you be able to see my full screen?
Yeah, right, sir.
Sir, visible, sir.
Okay. And I would like to just give an introduction, something like a bit of curiosity creating and a bit of not scaring the young people, but at the same time producing some curiosity to the junior budding Ilizarov surgeons. The characteristic features of Ilizarov apparatus are adaptation to various segments of skeleton and various types of fractures, capability of modifying and changing the treatment in between, capability of modifying position of fragments at any time of the treatment protocol. It is a single versatile device for simultaneous or sequential correction of angulation, translation, and also the rotation. You can see this, a few of one X-ray. This is a 2 months old non-union, or what you can say, he was an osteopath treatment, segmental fracture, comminuted at both ends of the segment. So at that time, this is very difficult to open and then do surgery for such delayed fractures who were there on osteopath treatment. So I applied Ilizarov and gradually distracted at both sides of fracture and gradually brought into alignment with using Ilizarov frame. You can see all the rotations are corrected, alignment is corrected, and you can see also some form of callus is seen. A few cases of, I have selected a few cases of each segment, something like that. This is a femur, 5-year-old boy with osteomyelitis of femur and extrusion of tube sequestrum, shortening and non-union without any sinus. The sinus has healed by the time he came to me. And so, but there is a lot of shortening. So what are the options in this case? He is walking with an equinus foot, keeping the thigh muscle taut. He runs and he walks. What are the options left? And what are the problems that we are going to face? Anybody would like to talk? Akansha? Hello, am I audible?
Please unmute.
Yes, sir.
Yeah.
Audible, sir. So, given the clinical condition that he has got sequestrum, which is extruding out, probably it is better to go in, remove the sequestrum by doing sequestrectomy, if required a saucerization. And given the limb line discrepancy that the child is having, alongside our intention to continue to mobilize him, better to debride thoroughly and give him a circular external fixator in form of an Ilizarov frame, sir, proximal 2 rings, distally, if possible, 2 rings, sir, and give him some form of stability. Eventually, plan for, after the consolidation occurs, maybe plan for a corticotomy proximally and advance with lengthening of that particular bone once the infection has completely settled, sir.
Actually, there is not much of sequestrum. The sequestrum has a tube sequestrum, like a tube. It has been extruded. Almost 3 inches of sequestrum has been extruded. So your this thing is correct, and so I planned for the Ilizarov fixator. And the problems are like very small boy with short bone. Accommodating transport mechanism has become a very difficult this thing in this. Rule of 2 rings per segment could not be accommodated, and fascial plates should not be damaged while doing the surgery. With this in mind, I have done a corticotomy as per your this thing at the middle third, upper third junction, a very short segment, only a 2-inch segment, and epiphysis has been spared at the lower end, and docking has been achieved, distraction continued. You can see it in the X-ray. But at the time of docking, I thought that it has united, but docking site has not united, and the region rate at the distraction site has consolidated. So I was forced to do a repeat Ilizarov without any distraction mechanism, only for the union at the docking site. He sustained, is a very naughty boy, very active, sustained fracture of the tibia for which POP was applied in extension of, to keep that limb in extension, a threaded rod in the POP has been included like an ebony cast so that he will not bend his knee. And during the second surgery, patient developed respiratory stridor and was kept in ICU for almost 10 days with a tracheostomy, and gradually recovered from the tracheostomy, and finally we could get him out of the ICU. Whatever that he has paid to me, a meager price, has more than that has been paid to the ICU by me. At that time, he paid about 10 to 15,000, and that much amount has been paid to the ICU. And the final outcome after solving all these continuous problems, you can see that the docking site going for the consolidation, and finally it got consolidated. But I was left with only 2 centimeters of shortening, recurvatum deformity, bit of recurvatum. I felt that this will be remodeled in due course of time because he is a child, and finally I could get the union. Any questions in this case, which I could have done a bit better way, or?
Very nicely case done, sir. This is good to ask the questions from the youngsters. What did they understand from this? We should have any question from the PGs.
Anything that you want to clarify, or anything that it is an interactive session. That's why I have put the slides like that, and anybody can ask, or anybody can anything in the chat box.
Nothing in the chat box or on OrthoTV yet, sir.
Hello, sir. The recurvatum in distal, Kuldeep here from Rajkot, Gujarat. Am I audible, sir?
Yeah.
Go ahead.
Am I audible?
Yeah, audible.
So in lateral view, your ring is in recurvatum. Probably that is a region.
Maybe, but it was very difficult to accommodate even that
No.
3 rings in
It
that.
was tough case, sir. if I would have to go, I would have probably used just a rail fixator, pediatric rail fixator. That would be a simpler and had a case done, and probably in a Gujarat tutorial we will I'll share, sir.
Okay.
But though with the ring you have done a nice job.
Okay, thank you. And coming to another case of upper limb, aseptic non-union after plating, after upper middle third of ulna. But the X-ray shows that something was done before. You can see, in addition to these screws that were with lysis, there were another additional holes that were seen. Maybe something was done before, maybe an X-fix or something else, but still it ended up in non-union. This is the first X-ray I have got. So what are the options here? There will be a lot of gap after excision of the sclerotic bone, and how to fill it. Is replating advised because it's almost 3 and what about nailing or ream the marrow cavity in such a bone with sclerotic obstacles in the marrow? Almost 6 obstacles are seen in the distal segment and 3 obstacles in the proximal segment. So what I have done, this is I have harvested a tricortical iliac crest, opened that, removed the plate, and tricortical graft has been harvested, which was pre-reamed before putting into the between the segments of ulna, and a nailing was done with through the sclerosed holes. It was very difficult to ream that, but somehow I managed to ream it in the distal segment. But even after that, there was some gap is seen at the proximal and distal sides of the tricortical graft. So what I thought is that I'll apply an Ilizarov frame to the upper end of the ulna and lower end of the ulna away from the nail. And I applied an Ilizarov frame here, and you can see a good compression and good callus. And this is the union after removal of the frame and range of movement of the patient. So a simple non-union can be treated simple by combining different methods. It need not be that you will be doing Ilizarov and you will be doing only Ilizarov on this thing. Should not be there in your mind. You can combine things and then still you can achieve good union and result. Anything anybody would like to say or question? Or
Yes, sir. My question, sir. It's a wonderful method done by Ilizarov. Instead of doing a transport, you get it short by applying the graft as well as Ilizarov. So just to give compression, or you gave compression distracted in both, sir?
Yeah. We could have done a corticotomy at the distal third and then gradually compressed it. That is one way. That is but still I'm showing the other method so that the things can be, because sometimes in the forearm what happens, the regenerate formation will be much slower and it goes for most of the times an hourglass appearance. So that is why I have selected this, and then I could get away with this.
Yeah, exactly. So that is the key point. So if you try transport in forearm, that takes so much of time, and shape is not very good. So this is a very good method of doing hybrid and doing graft plus compression. So just giving a graft and nail would not be enough. So a graft plus compression with Ilizarov makes it perfect, sir. Thank you, sir.
Yeah. Sometimes what happens, even the distraction site, sometimes you may have to graft it. It goes for an hourglass and then you may have to graft it there instead of here.
Right,
so we can avoid that, and then we can go ahead with something like this also.
Right, sir. Yeah. And so for elbow movements, you applied in the proximal part, you applied a full ring or a 5/8 ring, sir?
Half ring.
Half ring.
Or 5/8 ring, rather.
Exactly, sir. That is the main important point. So we apply 5/8 ring, so the movement can go stiff. Yeah. That's very important. Key point.
So that elbow movement will not be restricted, 5/3. But in the distal part, you can apply full ring and still you can get a ROM of wrist very well.
Yeah, these are very small points that has to be noted by the young surgeons.
Yeah.
Sir, one query. What is your call on putting a non-vascular fibula in the gap and both the ends of fibula with the cancellous bone graft from iliac crest? Is it feasible or just a tricortical is better? Because sometimes
that becomes the cortical bone becomes avascular stud like something like that. But a iliac crest, tricortical iliac crest will become like a what you can say with a lot of osteogenic potential. Yeah. That is why I selected the tricortical. Even though one cortex is not there, still you can reshape it and the cortex will reform in that. Once the loads are applied properly, you can see in the final image that you will not differentiate where the graft is like.
Where many a time where scenario is it is not around just 3 centimeter, it may be 4 centimeter, 5 centimeter.
Yeah.
And on that, people do say, and I have been across 3 cases yet to result come, where I have put in a fibula and cancellous bone graft on the either side along with plate after the infection has subsided. I'm yet to come up with the result, but yes, that is what I had done larger because as you said, it is bit cumbersome and it is difficult. Even I am also learning the Ilizarov in upper limb. I have been comfortable with the humerus, but forearm is tricky. So so that I had done.
And one more thing is in something like lower end of the radius also you can use, but the thing is that the iliac crest is curved. It's not straight. So it will be difficult if it is more than 3 to 4 centimeters or something like that. So you have to reshape it in a very proper way. Okay.
Sir, I have a question.
Hello.
Okay.
Hello. Dr. Prasad. Hello.
Prasad.
Very nice outcome. But I have done good number of cases by using fibular graft, because if it is small, 1 centimeter, 2 centimeter, we can go for the iliac crest. But if it is larger gaps, it is better to go for fibula.
Fibula. Okay.
Fibula.
So
that's what I am saying. If it's more than 3 to 4 centimeters, it will be difficult to accommodate that bow of the iliac crest.
So, sir, you had used vascular or avascular fibula in that?
Avascular.
Reddy, sir. Yes. Okay.
Avascular.
Okay, sir.
Sir, can I ask a question, sir?
Okay.
Sir, how long did you take to remove the frame, sir, in this case?
This case, once the compression is out and then once you see that callus is formed, you can remove it. But that how much time it takes, we don't know exactly. We cannot say that because it depends upon a lot of depends upon the vascularity at that point of regenerate.
So is
because
this
it's already sclerotic? Bone is already sclerotic. We cannot assess exactly.
So is this intramedullary implant also removed, sir, right now?
No, I don't think he has come for the removal. Once it is united, done, and they will not come back sometimes. Okay.
So also in the previous case, the pediatric patient, sir, how long did you keep the frame on, sir, for the child?
How much time?
Yes, sir. Yes.
Initially, it was about 7 or 8 months, and then again about 3 months.
After he developed the proximal tibia.
Non-union.
Yes, sir. Okay. If anybody else also has any questions, they can as well ask. Or they can type in the chat box. So there's a question actually that has been asked, how to gain length in such cases by Samsung.
By
somebody whose name is not showing up, sir. It's just a Samsung device.
Okay. How to gain length?
Yeah.
No, initial X-ray should show that the proper radioulnar and then the distal and proximal radioulnar joints are maintained, and then you will know how much is the excised bone, because the other bone is the guide for your gap restoration. So once they are in alignment, that is the gap, whatever the gap that is there, then that should be refilled.
And sir, Dr. Sridhar Reddy has asked a question, how to prevent an hourglass formation in such cases whenever we are trying to lengthen the bone? Yes.
In forearm, better go by about half mm or 3/4 mm per day. Instead of 1 mm per day in 4 divided doses, it can be about half mm, or if it is in children, it will be 3/4 mm. If it is adult, better half to 3/4 mm, something like that, depending upon the so that the hourglass region rate can be avoided.
Sir, and our Ravindra sir has asked a question, sir, regarding if you have any radiographs of the wrist.
Radiographs of the wrist.
Yes.
Then I have to check. Because his rotations are good, and then there is no prominence of the ulnar styloid. You can take it granted that the alignment is right. Dorsiflexion is good, and the rotations are good. There is no ulnar prominence seen. So the wrist is in alignment.
And sir, Dr. Tabish Rahman is asking if you have a photograph of the frame when it was in situ, sir, for the forearm.
Photograph of the frame.
So that is very important for the youngsters, where to apply the frame, where to apply the wire. The proximal forearm, the distal forearm, just tips for the youngsters, sir.
Okay. I'll just check, and if others are, then if others are, when others are doing, I'll try to share it if it is there with me.
Even you can see the on the patient, the ring on the patient.
Yeah, when it is on the patient, I'll try to, or I'll see some other forearm this thing, and I'll show you.
Or if you have an image of this one somewhere, maybe you can just share.
Yeah.
With
While Srinivas Reddy is tracking, I'll try to retrieve it. Okay.
Yes, sure, sir.
Okay. Okay. This is the case that I want to show initially, and this is the case that I have received. I don't know what classification that this will fit into. More than C3 or Schatzger type 5 or type 6, I don't know. It is called, I put it as bag of bones, 40 years male, open type 2 injury in RTA. Came to me 2 days after the injury. He was COVID positive on arrival, so I could not do him. Sent him back with the existing slab and asked him to come after 10 days for surgery. So he went back. And what are the options in this case? Anybody would like to do anything else? Or
So how is the skin condition, sir, in this case?
Skin condition, there were no blebs.
And Doppler and all.
Luckily, there were no blebs. He came with the slab on. And I opened it, I seen it, and then I advised him ice packs and elevation. And because he was COVID positive, I could not do it on the day. It was in first or second, I think. First, I think. It was the first.
Were there any blisters on the skin, sir?
No. No blisters. He came to me after 48 hours, but still there were no blebs. Because it was compound type 2, right, the pressure might have been evacuated by the injury itself, wound itself.
Right, sir.
Lucky. That is, in this type of tibial condyle fractures, if we have a type 1 or type 2 wound, the blebs will be much less.
Exactly, sir. So we should wait 4 to 5 days at least for the blebs to subside, and then we can put rings on it and give compression with Oli bars and distraction also, the joint spanning, sir.
Yeah.
Sir, since the patient was COVID positive, I believe there is a role for giving a skeletal traction in the distal tibia if there is no fracture, sir. And then probably waiting for the COVID test to get negative and then operating. at that instance. It would also decrease the intracompartmental pressure and decrease any slight chance of impending compartment to arise. That would be my plan, sir, while elevating it on a BB splint if possible, sir.
So almost like that, I have continued with the slab, whatever the day has come. So we were not touching the patients at that time. So I have sent him back and came back to my bad luck after 12 days. He hasn't gone anywhere and he tested negative. No blebs. Skin condition is reasonably okay with wrinkle sign. So what are the options? So I felt that Ilizarov is the only answer. There is no one single fragment that can be fixed like. It is just bag of bones, nothing else. No joint line is seen, nothing is seen. You can see that there is no joint line is seen. Intercondylar is different, medial condyle, lateral condyle. Everything is small fragments. And there is a step, and there is subluxation of the posterior fragment and anterior fragment.
Dr. Prasad, you need to have traction X-rays, number one, and number two, 3D CT before going further.
Yeah, I didn't have a 3D CT. He had a 3D CT, but I didn't have that picture of 3D CT in this case available with me. So with small, I have restored the medial condyle with one K-wire extending into the femoral condyle, under the femoral condyle. I restored the medial condyle first, so that one big fragment which is available has been restored. And the others I have gently manipulated with small K-wires and then stabilized them a little. And I have not put any Ilizarov frame into those fragments, but I have distracted that. First, initially, I have distracted that, applied the frame and distracted that, and then they started falling into place one by one. And you can see the restoration of the joint surface. And I kept the knee in distraction.
Sir, one question, sir.
Tell me.
Sir, did you try for olives, contrarily from both the directions for compression?
Because I felt that they may collapse further. Because it's all shattered pieces. So I thought that if it gives a little pressure also, it may get collapsed.
Just to hold, sir, because I've tried in a few cases, olives and contour olives just to hold. And even with oblique for buttress effect. And cutting the tip,
So I have not used olives because of fear of that everything may collapse further. Because there is no one fragment that even the small of cartices are fracture free or something like that.
Yeah, but this is a wonderful fixation, sir. It's a wonderful fixation. Yeah.
And once that is done, the medial condyle is stabilized first and remaining after distraction. The medial condyle also stabilized after the application of the ring and after the application, after distraction, so that the things will fall into place on their own. And then I have manipulated one by one, piece by piece, and stabilized with some few K-wires.
Sir, can I ask a question, sir?
Yeah.
Sir, is this all done percutaneously under Shyam guidance, or did you have to mini open some of the fragments?
Everything under percutaneous.
Dr. Prasad, is it done on fracture table?
No, it is done on regular this thing with two what you can say bolsters under the thigh and under the ankle.
Thank you. It's a nice reduction.
So at 3 weeks, I have added additional ring to stabilize the condyles, and hinges were applied at the knee and RYM started. At 3 weeks, I have added this. The previously that condyles were not stabilized with anything except K-wires, and now you can see that hinges were placed and additional ring has been added at just below the tibial condyles, keeping everything intact except for I removed the K-wire that is spanning medial condyle to the medial condyle of the femur. I removed that and I started movement of the knee using the hinges. And at 6 weeks, the ring above the knee has been removed along with hinges and continued with the ROM exercises. 6 months follow-up shows good union and restoration of the condyles, where this has been removed, and this is the final outcome with almost 80 degrees of knee flexion and extension.
Nice.
Any questions or suggestions or?
Just a question, sir. Sir, did you keep the distal until how long did you keep the distal femur rings in C2 with the hinges?
Distal femur ring has been removed at 6 weeks.
And any role for keeping it in distraction, sir? The joint, the knee joint in distraction when we are applying the ring?
No, for 3 weeks it was on distraction, but at 6 weeks additional ring has been added there for the tibial condyles, and hinge was given. At that time, the distraction and the K-wire has been removed at 3 weeks.
Right.
And at 6 weeks, the proximal most ring, that is in the distal femur, has been removed at 6 weeks, along with the hinge. Okay.
Dr. Mahesh has a question.
From Dr. Jagdish.
Dr. Mahesh Jali, yeah, please ask the question before we move to the next.
So, Dr. Jagdish has asked total how many rings in the tibia, sir?
Tibia, it is initially 2 rings only at the ankle and just below the fracture site. And afterwards, 1 more ring has been added to the tibial condyle.
And Aradhana ma'am has been asking, sir, if percutaneous technique is not possible, then is it feasible to open it up and fix it with the technique that you have mentioned, sir?
Yeah, it's possible, but it's possible, but there will be a lot of edema and it will be very difficult to close the wound. Even mini opens will be very difficult to close in this type of situations. Even though the wrinkle sign is positive, still you will have some problem in problems of wound essence.
So this was operated 10 days after the first presentation,
Yeah,
right?
12 days. Not even 12 days. He came to me and after 10 days. That means previously 2 days and 10 days. And then I have taken about 1 day or 2 days, something around 2 weeks.
Yes, sir. Okay. It was a very nice presentation, sir. So Aradhana ma'am is asking another question. If primary grafting is necessary in such a case of bone loss, sir?
No, if you could restore the condyles properly and the gaps in the cancellous area will get refilled very fast. If they are stable for about 6 weeks, they unite, they don't collapse afterwards. Usually they don't collapse after 6 weeks, even though it has been the distraction has been removed, they don't collapse after 6 weeks. So there is no need for grafting.
I just had a small question, sir. In case one of these fragments is large enough to be held with a cancellous screw, cannulated cancellous screw.
Yeah, if on both sides, if it is there are large segments, a bit of large segment, then you can add a CC screw to that and then stabilize them fast, and then you can go ahead with your regular fixation. But here there is no segment that can take even 1 screw or 1 olive also even. That was my worry. It's just a bag of bones, nothing else.
Very nice presentation and a very wonderful outcome, sir.
So you applied 5 bed rings of full rings in the proximal tibia, sir? And
full rings only. Full rings only.
Yeah.
Because I am not expecting a full flexion in this case.
Yeah. Right.
At least if you could get about 90 degrees of flexion, I'll be happy and the patient will be happy. So, till the ring touching the posterior skin, he
Yeah.
can flex it with full ring.
Right, sir. Perfect, sir.
If anybody else would like to ask any questions, please ask. Sir, Dr. Karthik Reddy has asked, how do you manage pin tract infections in such cases?
Pin tract infections, usually they will not be there. If you are very good at putting it, if you don't produce any dermal necrosis and you take care of the skin properly, pin tract infections are very minimal. Very minimal. You have to do the regular dressings and you should see that there will not be any dermal necrosis while applying the Ilizarov wires. That is most important thing. Otherwise, there will be pin tract infections. Anything else or shall I close?
Sir, Dr. Karthik Reddy has asked if daily pin site dressing usually solves them whenever there's a pin tract infection.
Okay.
Like in the sense, whenever there is a pin tract infection noted, would you go for a BD dressing or a TID dressing of that sort, sir?
No, that much I didn't face.
Sir.
Basically, if there is an edema, these are all holes. The edema will come out of these holes. So, train the patient that there will not be any edema on the leg. Keep the elevated. Once he walks, it's okay. But when he is not walking, usually our position of sitting is like we sit in like in a chair. That should not be there. If he is sitting, he should keep the limb elevated on another chair or something like that. Then the edema will not develop.
So we can continue, sir, with the sclerotic non-union slide of you.
Can I continue or can I stop? Because Srinivas Reddy is there and 9 o'clock it is, and if you want, you can.
This looks an interesting case, sir. You can have
This
this.
looks like an interesting case. Okay. It is a sclerotic non-union of the tibia with a broken V-nail. The young budding surgeons might have not seen a V-nail, but you can see it here. It was the treatment of intramedullary nail during 90s and 90s. And it has got broken and with a varus procurement deformity, avascular bone ends, totally sclerotic. You can see the white, fairly white bone ends and shorting of the tibia compared to fibula. What you want to do in this? Fairly white means, even though it is hypertrophic, usually we say that it is almost like avascular. Hypertrophic usually we call vascular, but this case, this fairly white is avascular. So nail removal is through a small window and Ilizarov frame application, catectomy at the upper end for gaining the length and also to increase the vascularity to the limb. That is more important. And you can see the catectomy, you can see Ilizarov frame application and distraction apparatus for that. And solved all the problems identified earlier. Sclerosis just vanished by way of catectomy, which increased the vascularity to the limb, and stability looked after the hypertrophy at the fracture site. Catectomy also has given the necessary length. And one more case I would like to show you. This is very interesting. Regular humerus fracture with a small comminution. Fixation was not so well executed. Might have added another screw at the upper end in the first place itself. There is interfragmentary screw. But finally, there is loosening of the implant. So what next? So anybody will prefer a nailing or a proper plating with a number of increased screws and better purchase. So the other surgeon has done a 8-hole plate with 4 screws on each side. But again it started absorbing at the fracture site. This is the situation when I have seen him for the first time. And this has been posted in a live demo of IGOF workshop at Vizag. I was worried a lot and what I am going to do with this. So almost like beads of bone are seen in the distal segment, which may not survive at all. I have to excise the whole thing. And bone transport has to be done from distal to proximal. Patient is already having a radial nerve palsy. So somehow I managed to do the catectomy at the distal end and remove the beaded portion of the bone. And finally I put them in alignment, and you can see good consolidation. And you can also see that his dorsiflexion has been full. I don't know how the catectomy has helped, and vascularity, increased vascularity has helped him to recover his radial nerve palsy. So with this type of cases also, you can manage. Even the nerve will be recovering with the vascularity, increased vascularity. Another case for shattered tibia femur, lower third, and 3 days after open type 3 fracture. 3 days he was in government hospital with only initial debridement in the casualty and fixation with LCP after 3 days at a corporate hospital. Got infected, again debrided, removing all the loose fragments. And so what are the options now? So finally what they have done is they have removed everything, including implant and also the bone with a clean cut excision. He came to me with this in a brace, the long knee brace. Luckily no sinuses, large gap to fill, but I observed that there are faint traces, efforts by the body to regenerate on its own without our interference. With our interference, it got infected, but without our interference, you can see that there are streaks of new bone formation here and here. So I have taken the strategy of watchful expectancy and masterly inactivity and just applied the frame, done nothing except giving it stability and waited for the regenerate to consolidate. And this is the final outcome. Even though it looks in valgus, but somehow the clinical picture is not in valgus. Thank you. Any questions?
So you have to do according in this case or just left as such, sir?
Just left like that, just stabilized. And the whole bone formation was on its own, except there is one, you can see that there is one small fragment here. This gap I have filled with a bone graft afterwards. Around this, I have kept some bone graft. Around this, you can see that there is a new bone formation around this. This small island of bone is there. I have not removed that, but I kept another bone graft at the end of it.
Right, sir. It's a wonderful example of radial healing. Yeah.
Nothing, I have done nothing except giving him stability. So the body is having its own regenerative capabilities. Help it, and it forms on its own. Help it to stabilize and then give some mobility and give some stability, and it will unite on its own.
It's the beauty of healing.
We have a question, sir, for this amazing case that you have presented. That how long was the frame applied in this case, sir, for giving it stability and forming the regenerate?
It took almost a year.
Okay. And so one more question regarding the tibia case, sir, bicondylar tibia case. Dr. Gautam has asked, what was your initial plan, just to apply a frame and give a rigid fixation, or excise the sclerotic bone completely and do corticotomy? The previous hypertrophic answer.
Hypertrophic case I want to remove, and then my plan was that only. My plan was that only. Remove and then bone corticotomy and distraction, correction of the angulation.
Okay, sir. Sir, and one last question from Dr. Jagdish Garkoti. He's asked regarding that bicondylar tibia case, sir, where how have you fixed the posteromedial and posterolateral fragment with just K-wires on?
Just K-wires, nothing, no fixation was used. When the muscles, the ligamentotaxis will put them together. When you distract it slightly, everything will fall in line by the effort of the muscles.
And Dr. Madhavi has asked a question, sir. In this case that is presented, in the later stages, is arthroplasty possible?
Which one?
This one, sir.
Tibial condyle? Or
the last case, sir, that you presented, femur.
This one, arthroplasty is possible or not. If he is not having knee flexion. So whether it is possible or not, I don't know exactly. I am not a joint replacement surgeon, but he is not having at the time. By the time he came to me, the distal fragment was moving rather than the proximal knee joint.
Sir. Okay, sir. Very nice case presentation, sir. A lot of learning from each of those. Very inspiring to see the results as well at the end of it, sir.
That is what I thought, and then I kept a few cases that can inspire people, something like that.
And last question, sir, from Dr. Sridhar, if you have any walking video of this distal femur patient, sir, this last case.
Distal femur?
Yeah, sir, because there's some shortening. So have you given any kind of a shoe raise or something like that?
This is a bit short, and so shoe raise was given to him. About 4 centimeters of shoe raise was given to him. He was not willing for any more surgeries, and he was happy with. He thought his leg is going to be amputated, but somehow he managed to get it, and he was happy for that.
Okay. Thank you so much, sir, for all the wonderful cases that you presented tonight. If anybody has any other questions, please ask. Then we'll move on to Srinivas's class.
Prasad, sir, please call him and lengthen is 4 centimeters from proximal femur. he looks young.
We have a question again regarding this distal femur case from Jishnu Barua, sir. So has there been any issues with uniting the cortical bone ends with cancellous condyles of the metaphysis?
Which one? Cancellous?
Distal femur case, sir. Did you have any issues when you were uniting the cortical bone ends with cancellous condyles of the metaphysis of distal femur, sir?
No. No, only I have used the graft where there was an island which was left alone from the main stream of formation of the bone. So that small island I wanted to incorporate, and so I have added some bone graft on that side. I have not removed the island. I have added some bone graft around that, and it got incorporated automatically.
Okay, sir. And sir, one last question from Dr. Tabish is what is the knee range after removing of the frame, sir, in this case?
No, he doesn't have knee range of movement. He is stiff knee. I could not get it.
Okay, sir. And so with that, we will move on, sir, to Srinivas sir's presentation. Much awaited.
Thank you. Thank you.
Yeah.
Thank you everyone for the interaction.
Thank you so much, sir, for coming tonight and sharing all that information and knowledge.
Thank you, sir. Thanks a lot, sir. Jishnu sir, we like to come live on video and give some tips. You're a very senior person. Jishnu sir, are you there?
Yeah. Hello.
Yeah.
Sir,
Hello.
is my screen visible, sir? Srinivas sir's slides are visible?
Yes, it is clear. You can open it full screen. You can make it full screen.
It is full screen, sir. Is it not visible on full screen?
It is
It's
visible.
visible. Please.
Okay, sir. So we shall begin with Srinivas sir's presentation on the basic instrumentation. Sir, should I go on to the next slide, sir?
Yeah, you can. One minute. Just thank you, Akansha, for a great introduction of me. And I'm apologizing for the technical glitches which I had from my side. And as the theme goes, it's back to basics and learn today and learn and lead tomorrow. It's very nice, Akansha, which you have given the theme. And based on that, most of the time we'll be presenting very complex cases. And most of the participants and the group, which consisted of young and budding surgeons, I felt, because the basics are very important, and basics of the basics. The instrumentation is the first thing which everyone has to be confident of, that. Know your instrument first. In the next slide.
Sir.
Yes, the Ilizarov instrumentation is the basis to usher into a successful Ilizarov surgeon, because it consists of primary components and the secondary components. Primary components, as most of us well know, known thing, it is which connect from the bone to the skeleton to the finished frame. That includes wires, maybe olive wires or plain wires, and the wire fixation bolts and the rings, and all the other components which form the frame, which stabilizes the frame. They are called secondary components. Maybe the connecting rods, hinges, nuts and bolts, telescopic rods, and many other items. They form the secondary components. Next one. Yeah, and the first before. Yeah, this is a wires which includes olive wires and the plain wires. And the olive wires were two different sizes, 1.5 for the pediatric, and even for the adult humerus we can use 1.5 wires, and 1.8 wires are the common wires which we use in the adults. And the length would be about 400 millimeters or 40 centimeters. And olive wires, which this consists of a bead. This consists of a bead in the near to the tip, and the tips of the wires would be two types. One is the bayonet tip, another one is the trocar tip. Bayonet tip for the hard cortical bone, diaphyseal bone, and the trocar tip for the diaphyseal bone. And the other instrumentation fixation devices include the Shyam pins, which are of different sizes, different lengths, depending on the situation. 5 millimeter, 6 millimeter tapered pins, round ends. These are different pins, depends upon the choice of the surgeon and depending on the type of the bone which we are dealing with. Next one. And the wire fixation bolts, which is of, one is the slotted, another one is the cannulated one. Slotted, which we use most of the time. Slotted consists of when the wire is a little bit eccentric to the hole which has exited, then we use the slotted one. And the cannulated one, when it comes to the center of the hole, we use a cannulated one. Cannulated is a slightly more effective than the stability wise than the cannulated, but many a times we'll go for the slotted one. Next one. And about the rings, generally we use half rings which join together to form a full ring. And the mode of fixation, the alignment of the two rings is like this, like a shake hand fashion, not the otherwise. It should be like this, it should be. And generally better to use the same company rings, because the number of holes, all those things would be the same. Better if you are using Pitka rings, better use Pitka rings, 2 half rings, and that would be a better one. And 2 same diameter should be used, same diameter. The inner diameter is from this point to the maximum diameter, that is the size of the ring. Because if it is 140, means 140 millimeters from the here to here is called 140 ring. The number of holes vary from depending on the company. Okay, and the rings would be placed in a tray, or different sizes. We have to arrange them in a tray. And these half rings also we use sometimes as a unit. Half ring will be used in the cases of equinus deformity. Sometimes we use them some other place also, depending on the requirement. And the connections would be like this. And next slide. Next one. And the other types of rings, this is the omega ring, which we use near the joints. Proximal humerus, we'll be using the omega ring, which is an extended outrigger like that fashion, and 5/8 ring will be using at the elbow joint to facilitate elbow range of motion. And full rings, it's just for the description sake, we are using, I'm telling you, this full ring, it's not even manufactured by most of the companies. And full ring, the advantage of full ring is it has more number of holes, and it is more stable, but hardly we use them. And it is, if at all we want to use it, we can use in the distal tibia. And this is a composite ring, carbon fiber ring. These composite or carbon fiber rings are lightweight rings, and it's not that stable when compared with the steel. And we can use them. It's a radiolucent, where we can use near the joints, like tibial platform fracture. We can see the fracture growth, callus, how the fracture is progressing. And this is a foot frame where we can use near when doing the surgeries in and around the foot. Next one. These are the arches, different types of arches. And one is, these are called Russian arches, different sizes. The diameter of the arch is definitely larger than the diameter of the ring. And these are used near, especially in the proximal femur, and the smaller arches also used near proximal femur, or we can use even the proximal humerus also. These are the Italian arches. And this clamp, shank pin fixation clamps are to be used with these openings. And this is, we can use rancho cubes also. These are, depends on the choice of the surgeon. We can use either Italian arches or the Russian arches. And Russian arches, a little bit positive point about this, number of holes is more, and it is a little bit, I feel it is a versatile. Next one. Next one. Okay. And these are the nuts and bolts of different sizes, 1 centimeter, 10 mm, 16 mm, 20 mm, and 30 mm. Depending on the requirement, we can use a different size of the bolts. And these are the nuts, which we see different. It's about the wrench will fix, is a 10 mm wrench will fix here. And this is a nylon lock, nylon nut, where we'll use at the time of distraction and angular deformity corrections, like that. When the knee flexion deformity is there, we will use it in the nylon locks. This won't fix that stable. It will allow some movement. And this is a quadrangular nuts, where we can use in at the time of distraction in lengthening. It will have dots, 1, 2, 3, 4 dots. The patient, it becomes easier for the patient to move the nut in the desired direction, so that the distraction will be occurring. And it is confident, the patient will be more confident if you use these quadrangular nuts in the cases of distraction. And this is a quadrangular nut. You see the dots are there, where we will find these dots. The patient first the patient will move to the another side. It will be 3 dots, means it moves about 90 degrees from the existing position. So that 90 degrees means it will be 1/4 of a millimeter distraction will be there. And these are grub screws. Grub screws are the added items, or they are not in the original Ilizarov armamentarium. Generally, we go for the 3 mm grub screws. This 3 mm grub screws, and this is Allen keys. These are used in the cases of shank pins in rancho cube, in the rancho cubes, where we'll be putting these grub screws, so that there won't be any outrigger effect. They will be inside and flush with the rancho cubes. Instead, if you use these bolts, it becomes obviously they will be above the rancho cubes. It is better to use the grub screws in the case of shank pin fixation in a rancho cube. Next one. Next one. There's one slide missing, it seems. Go back.
Wrenches, sir.
Wrenches just before the wrenches.
The nuts and bolts.
Next one.
Wrenches, sir.
Okay, these are the wrenches, which generally we use the 10 mm, and one side will be 11 mm. This is a ring spanner, what we call, and it's an open spanner. We need to have generally we use 10, but we need to have 13 mm also, because for the rancho cube it comes to the 13 mm, and for the general nut and bolt it will be 10 mm. And sometimes we need to have open also. In some we can't, sometimes it becomes very difficult if you use a ring spanner. In certain situations we can't negotiate that particular situation when there is a lot of congestion in and around the fixation. Next one. And this is the tensioners. These are the tensioner. This is a manual tensioner. This is a regular wire tensioner. This is a dynamometric wire tensioner. This consists of gradations consisting of from 50 to 130 kgs. This will hold. This consists of this handle, and this is the graded one, and this is a fixed jaw. One is a fixed jaw and one is a mobile jaw. And with this turning the clockwise, we can have it will hold the wire, and then it will be holding the wire, and then it will give the proper tension. And this tensioner is a regular tensioner, wire tensioner, where the how we don't know how much tensioning we are doing on the wire. Next one. And these are the rancho cubes of different sizes: 1-hole rancho, 2-hole rancho, 3-hole and 4-hole ranchos. These depending on the situation, we can use sometimes two shank pins in these rancho cubes, in 4-hole rancho cubes, one alternating the other, and 1-hole ranchos most of the times we'll using. Next one. And these are the hinges, and consisting of low profile and high profile hinges, where this male hinge, which consists of a threaded rod at the base, and female hinge, which consists of a threaded inner hole. That this is a monoplanar hinge. This is and these are the hinges. This is a twisted hinge. Depending on the situation, we have to make use of what hinge we are using. Then next one. And this is the post. It is a expanded version of the hinges, consisting of 3-hole, 4-hole, 4-hole posts are there. And this is a male post, and this is the female post. Next one. And this is a oblique connecting rod. In general, we'll be using oblique connecting rods in the proximal femur when we want to have a larger radius fixation. Larger radius fixation means, if you just connect the proximal Italian arch to the ring, what happens is it becomes like a monoplanar fixator. What if you compress it, it goes into valgus deformation. So, and if you distract it, it goes into varus deformation here. So in order to reduce this effect, what we do is we will expand the radius of fixation by, it is about, for example, if you see, this will be about 60 degrees like that. So if you want to make it 120 degrees or more than 240 degrees, what you have to do is you have to bring these posts more and more anteromedial and posteromedial, so that it works like a full ring. So that is a basic motive to use these oblique posts. It spans the diameter. Next one. And these are the connecting rods, different types of connecting rods. This is a slotted connecting rod. These connecting rods are different sizes are available, and this nut will be fixing to this. And this is a slotted connecting rod. This is a slotted connecting rod. A wire will be passed into that, and two nuts are passed, and you can have a tension on the wire, so that if the olive wire, if you use an olive wire, if it is for the loose fragment, you can have a compression effect, and that fragment will align with the main fragment. So that like this, we can use a slotted rod. Next one. And these are telescopic rods. Generally, up to 15 millimeters, we can use the connecting rods. More than that, what happens is if you use the straight rods, what I said just before, the stability would be less. So it is better after 15 centimeters, use this telescopic rod. Telescopic rod consists of one threaded portion, and this side there will be a hollow portion. Hollow portion will be a place for the connecting rod, and this will have a bolt where it fixes. So if you use these telescopic rods, what happens is, on the whole, the stability of the frame increases. So this is a graduated telescopic rod. This is a graduate, consists of four sides. It consists of 4 sides. So if you turn the graduated telescopic rod, it moves 1/4 of a 90 degrees movement. It produces 1/4 of a millimeter compression or distraction desired based on the type of turning. Next one. And these are the plates
This will be fixed to the main ring, and this is the distance between these two is 10 mm, and these two rings will be 5 mm, and these are used when there is when the rings we use of different sizes, when there is a not congruence of the rings is not there, when we want to do multiplanar attachments, we'll be using these plates, and this is a extra plate with extended rod, extended connecting rod, and this is the twisted plates. These twisted plates will make the horizontal plane fixation to a vertical plane fixation. These are the extension curved plates which we can use in order to increase the diameter of the half ring, like that. And these are the other twisted plates of different sizes. Next one. And these are the washers which we use in different situations. This is a quadrangular washer where we use it for in the cases of wire fixation bolts, when the wire is not in parallel to the, when the wire is, there is a difference, there is a gap between the wire and the ring. We use these washers, and this is a slotted washer which will have a room for the wire, Ilizarov wire, and over that we can put a bolt, and we can do tensioning also. This is oblique washers, conical washers, and which consists of they are two mated together, and when the rings are not concentric, we can have some angular adjustment we can do correction of that angular when the ring is not parallel. This can be used. They produce without any offset. We can use these conical washers. A pair of them should be used. Above one pair and below one pair will give a good fixation, so that that rod which we are connecting won't be a bent one. These are simple washers. Next one. And these are the sockets, hexagonal sockets, and these are used when in order to connect two rings. It gives more stability, different sizes, 10 mm, 20 mm, 30 mm, 40 mm, like that. This is the spacer bushing. This is a bushing. This is a smooth portion will be there, and there will be a threaded portion will be there in the bushing. And sometimes this slotted rod, which I have mentioned, will be gone into this, and we can have a distraction of that. We can have a distraction of that in the bushing. So like that. Next one. And these are the osteotomes used for the corticotomy purpose. These are serrated edges osteotomes. Osteotomes of different sizes will be there. 5 mm, 10 mm, 15, and even up to 20 mm. But most of the time we'll be using 10 mm osteotomes. 20 mm is rarely used. And corticotome is another one which we will use, which consists of a edge like this, a little bit edge like that. Next one. And in special situations, Ilizarov fixator in special situations, we'll be using Ilizarov fixator. In syndactyly cases, it's a hand Ilizarov. Hand Ilizarov will be using, and what we do is we will be distracting these two areas. This will be distracted, and what happens? The skin gets stretched off, and after that we have to go for surgery. But anyway, with sufficient skin in between, we can perform a safe syndactyly surgery later on. And sometimes pediatric Ilizarov, almost the same, but the size of the rings, but the weight of the rings would be less. It will be a lightweight devices in pediatric cases. Next one. And how these next, just before maintenance of the fixation fixator, these devices are made up of 316L for the Shyam pins and for the Ilizarov wires, and for all other instrumentation, the steel used is 304 SS. And these instruments, they can be used for repeated usage, except for the wires and the Shyam pins, until there is a worn off effect will be there. Like if it is a nut, the threads will be gone off, and bolts also threads will be gone off, and the rings, they may break, and rods, they may bend. Like that, in such situations, we have to discard the those hardware, and the remaining things we can use whatever the number of times it is working. So next one. Thank you for the nice hearing.
you, sir. That was a very comprehensive lecture.
Yeah.
If anybody has any questions they would like to ask, any senior residents or postgraduate students who are with us.
This is a basic lecture, actually. I think.
There is a question on
Basic, but
OrthoTV.
very, very elaborate, sir. It's very important, sir. Knowing the basics is very important to do a surgery, sir. It was a very wonderful lecture, sir.
Yeah.
So there's a question on OrthoTV, sir, as to how much angulation can you correct with the conical washers?
7.5. It's not correction, actually. When they are not concentric, when we are unable to use the straight rod, we can use a conical washer, one above and one below, up to 7.5 degrees only. Beyond that, if we want to put a connection, we have to use multiplanar hinge.
That was the one question, sir. So if anybody else has any questions, please ask.
Yeah.
Someone wants to see a forearm. If Ilizarov image, something like that, if is there, I can show that few images.
Yes, sir, I wanted to see.
Sir, can we continue with sir's next presentation and then go to sir's live video?
Okay, no problem.
Yeah, sure, sir. So, Srinivas, sir, I'll start your answer.
Yeah,
yes, sir.
Hmm.
Yes, sir. Just a moment, sir. I'll just share the screen. So, is my screen visible to everybody?
Yes. Full screen.
And is it in full screen, sir?
Yeah, it's okay.
Sir. Yes, sir.
Yes, yes. This is a open fracture tibia. I'm going only for a single case, actually. It's only a single case which I'm presenting now. This is following road traffic accident. He has some other injuries, but they are not of significance. This I'm showing you. This is a grade 3 open fracture, which you are seeing obviously on the screen. Even anteritibial dorsalis pedis is not felt, and neurologically is stable. And this is the wound. This is the wound, what you're seeing. This is the fracture of tibia and also the fibula. Akansha, next slide. Okay, and you see the again on the during the operation theater. This is the picture, and this is the X-ray, which is extending into the lateral condyle of the tibia. And this is these are the comminuted fragments. Some of them are exposed outside, and they are bare bones also, without any soft tissue attachment. And this is extensive fracture, and this is a segmental fibula, which is seen at the neck and also that. And this is the same fracture at the lower side, which included the ankle. And so what my thing is, what are the options for this case? Okay, next one. Okay, this is a stage 1 fixation is done, and the condylar portion, lateral condylar portion is fixed with a K-wire, and also a Shan's pin is passed through that. A couple of K-wires is there, and a couple of K-wires in the distal part. And this is the wound. Actually, what I see is a partial closure is done, and without much of tension. No plastic surgical procedures were performed, and this part is grafted with partial thickness skin grafting, and wound has become healthy with debridement. And this is the thing. And next one. And this is after wound healing. After about 1 month, I have put a touring fixator, and proximal and distal. And I did next one. Can you go to next one? Okay, this is the final picture. Next, go back. Go back. Okay. So what I did is, this is a case where we can go for 2 ways. One is corticotomy and bone transport,
And for a change, I wanted to go for the fibular transport. This is one of the options left. So in this case, what I did is, this is a fixation with two olive wires. We did a transport of the fibular transport is done. And this, you see the direction of the fixation. This is anteromedial. This is anteromedial fixation is done. And very gradually fibula is translated anteromedial, because fibula is posterolateral, and that portion of the fibula, which is segmental fibula, is past two olive wires, and it is gradually shifted medially. It's gradually shifted medially, and it is after getting into alignment with the main tibia, fracture above and below, and it is docking is done. Next one. And this is the final X-ray, which is showing a proper union, and this is alignment is okay. I believe this is 3 years follow-up. This is 3 years follow-up. And the other things which I want to say is the fixator time is really long. 1.5 years the patient was in the fixator. That is the thing. And next one. And this is the clinical follow-up. This is a clinical follow-up, and range of motion despite intercondylar fracture, and it is really good, and the patient is nearly carrying out all his activities and pain-free. Next one. Okay, here the learning points are there. There are certain learning points which we can conclude. In the open fractures, for an orthopedic surgeon, we need not go all the time. We need not go for the expensive plastic surgical procedures all the time. We can go for the simple methods of closure. If at all, we can go for the partial thickness skin grafting, because that saves a lot of economy to the patient, and the surgeon, orthopedic surgeon, becomes more and self-reliant and more confident about himself, apart from the finances. And union time is so fast. Union time is so fast. Really speaking, union time is faster with fibular transport, but the fixator time is longer. Here the difference which we want to make it. Union time is fast, but the fixator time is longer. We have to keep the fixator for a long time in order to prevent refracture of the fibula. And the striking difference which I observed from the corticotomy and from the fibular transport is pain is less. The patient is so compliant. During the entire 1.5 years, the patient is so compliant. The patient didn't complain of much pain, because there is not much physiological, meaning the disturbances are less, like that of distraction, all those things are less. And the inflammation, basically what I want to say is, inflammation part is very less with the fibular transfer, and the scarring of the skin is also very less, and the edema is less. Edema is really less, and patient is very comfortable. Even though time is more, the patient is very comfortable and compliant with the fixator. And the fixator is also not a cumbersome. It consisted of minimal fixation points. And what I did is, after first surgery, I used a middle ring with 3 wires which are going to fix the fibula. That's only 3-ring fixator was there, and knee, foot, and ankle movements were very acceptable. Consolidation time is longer. Needed some protection after 1.5 years. Also, it needed a brace protection for about a year. It's not technically a difficult procedure, but in certain cases, it's if the gap is much more, definitely we can go for a fibular transfer, which is a treatment of, and it's a promising method of treatment, even though surgeons, even the Ilizarov surgeons also, it's not a very, we may not be much experiencing in these. These are what I call is a rare indications of Ilizarov procedure. It's not difficult. It is a reproducible procedure. And what I want to conclude is, biological fibular transfer is a time-tested procedure, and it can be recommended in indicated cases. Thank you.
That was a wonderful case, sir. Lot of new learning points to take from there. Sir,
Yes.
I have a question.
Yes.
After doing the Ilizarov fixation, you start weight bearing immediately, or did you wait for a while, sir?
Weight bearing is, we can go for weight bearing. It's not a contraindication. We can go for weight bearing as much he tolerates.
Sir.
Before
And-
fibula transfer.
So yes, sir. Yes, before fibula actually got consolidated into the femur, did you give any weight bearing, sir? That was my question.
Weight bearing is okay. Weight bearing is advised. Weight bearing is advised.
Reddy, sir. Post-op X-ray.
Go for.
No post-op X-ray was there, sir.
Yeah, it's not there.
I'm
Yes,
I'm
yes,
confused
yes.
how it have been
Yes,
pulled.
yes.
I could not understand.
Okay. Post-op X-ray,
Could have been a better one.
better one. Yes. It is there. Because somewhere missed it, but it is there. Post-op X-ray is there.
So there's a question from Dr. Nikhil
Yeah.
regarding instrumentation. Any specific company implants would you prefer?
Instrumentation. It depends on the surgeon. Actually, there are different types of instrumentation which Ilizarov manufacturers are making. Different companies are there. It depends on the choice of the surgeon and economy also. Some companies, the quality would be more like Pitker. I mean, it would be a little bit expensive. It is a choice. It's a choice of the Pitker. Definitely, the quality is very good.
And sir, Dr. Madhuri has a question for you regarding this case. If this is called as tibiofibular synostosis.
Yeah, it happened like that. Finally, fibula, it unites. It has united with the tibia. It will unite with its parent bone comfortably. Happens because what I want to say is generally, we will be calling as vascularized fibular graft as a great procedure, no? But this is muscularized and vascularized fibular transfer. You see, we want to coin a new word, muscularized and vascularized, which is richer, which is possible only with the biological fibular transfer in Ilizarov method.
And Dr. Karthik Reddy has asked a question, sir. If the fibular transfer has been done gradually, or has it been done intraoperatively at once? So, what is the rate?
It's a biological fibular transfer. What I want to say, biological means we'll be moving about. I did 2 mm into 4 sitting 4 times. 2 mm means 8 mm every day. 8 millimeters every day. 8 millimeters of anteromedial translation.
Is it osteotomized before, or it has broken on its own?
I used the broken already segmental. No, I used that. My job is made easier.
Very easy.
Yeah. Of course, it is easy also to break fibula. It's not much difficult.
Yes.
Sir, I'd like to take a moment and just welcome our Telangana Orthopaedic Surgeons Association President, Dr. B. Vijay Bhaskar, sir. So welcome, sir, to the webinar.
Yeah, thank you. Thank you so much. And I welcome all the members who academically enjoying today's session. Thank you so much.
Thank you, sir.
Good evening, Dr. Vijay Bhaskar.
Good evening, sir. Good evening.
Good evening, Dr. Vijay Bhaskar. Hi, hello.
Yeah, hi.
For taking your time out and coming live from your car. Sir, there is a question actually, Prasad sir, there's a question for you, sir, from Dr. Karthik Reddy regarding the distal femur case, sir, the last one that you presented. How did the bone from the distal femur in the proximal segment automatically form?
This is a natural response of the body to regenerate itself. And so I observed that there is some streaks of regeneration formation between the two fragments, even though there is a large gap. So I thought that stability will give rise to further formation, and then I just given the stability. That's all, and the body has done on its own. It is only observation, sheer observation, that whether it is forming or not, because by the time they came to me, it's almost maybe around 3 months after the injury, I think. And he came with a brace, and the brace might have protected to some extent, protecting the regenerate to some extent, but with a little of translation and rotation. But still it has formed. And so I observed something meanwhile, and so I used that as my rather catectomy and then distraction, whatever that we see in the initial stages. I thought that it is something like that, and then I stabilized, and it has gone for good union in due course of time.
We can consider, sir, we can consider like a myositis ossificans kind of thing.
No. Myositis is...
No. The strip top periosteum during the injury could have, and the good vascular muscles mass in the femur, that could have helped that gap to fill up. That does not usually happen, but maybe the strips of periosteum would have left.
Yeah, because almost it is operated. Almost it is operated 3 times.
Yeah.
Initial debridement, the first fixation, and bone excision, loose fragment excision, and then the bone excision and the plate removal. So almost 4 surgeries in a span of almost 3 to 4 weeks time. And I don't think that periosteum is left or something like that. I don't think so, because of so much of comminution and all these things.
Sir, there's a question on the same case, on the previous case, sir, the one with the canal, from Dr. Ubaidullah Sheikh. He's asking as to how to differentiate between hypertrophic non-union and the previous non-union with pearly white callus. Are they the same?
Usually hypertrophic non-union is wider than this, but of the same, what you can say, this pearly white, this thing will not be there in regular hypertrophic non-union. The callus doesn't look like pearly white. This is pearly white. The sclerotic non-union is pearly white in X-rays, and the other hypertrophic non-union is not like that. It is of the same texture and appearance as the remaining bone.
If anybody has any questions, please ask.
Normally, in Reddy's case, normally what we do a long bone transport that takes so much time. So, sir, in this case, how much time it took to do a fibular transport? And we do a
no, fibular transport, it about 1 month only. It happened in just 28 days, 25 or 28 days it happened. People are coming into the position of tibia.
And for the consolidated, sir?
Consolidation. And so union was so fast. Union happened so fast because fibula uniting is proximal and distal. But the only thing is I left the fixator for longer time, just protective. Because when fibula united, the patient's pain has dramatically came down after the union. Only the fixator was there as a protective device.
So for how long, sir, it was there, sir, complete?
Yeah, it's also consolidation and tibialization. What I want to say is union is over. It's rather than consolidation, it is the tibialization part.
Exactly.
The left one is tibialization part.
Increasing the thickening diameter of the fibula. It takes longer time.
It takes more time.
Around 1 year. So what is the total duration in this case?
Total duration? Yeah, 1.5 year fixator, 1.5 year fixator, 1.5 year post fixator. 3 years right now. From the date of injury, it is 3 years. The X-ray which I have shown.
So that is a wonderful phase. Otherwise, we done a trifocal corticotomy to take a very long, sir. The bone transport from both the sides here. And did you apply any brace for that after that, sir?
Yes. I have given a brace for more than 1 year. Protective brace. He was very important. He was comfortable just to prevent fracture, to prevent a refracture. So what the guide for this, what the learning thing from this is, we can go for a fibular transfer in larger bone defects rather than always going for the corticotomy. And this is also a method. What I want to say is this fibular transfer is also an assured method of covering the limb length discrepancies.
Right, sir.
So there's a question from Pritish sir. So does fibula transport risk injury to the anterior tibial neurovascular bundle?
Anterior tibial? No, not at all. Because it's a gradual, it's a biological fibular transfer. We will be taking care of that. We'll be moving fibula. It's a very slow pace. 2 millimeters, 2 millimeters in 8th hour, like that. 2 millimeters. Very slow, and we'll be cautious. We'll be looking after the neurovascular status frequently. So it's not a risk. It's not an acute translation. It's a gradual translation over a period of time.
Sir, do you have the post-op X-ray by any means so that we can share, sir, right now?
Post-op X-ray?
Yes, sir, for that case that the doctor from Gujarat had asked.
Yes, it is. It's having actually. Post-op. I will check.
So in the meantime, if there are no more questions, then Sir Prasad sir, would you please share your video that you would like to show regarding the forearm
Not
fixation?
the video, but the what is this forearm? They have asked how the frame looks like in forearm.
Yes, sir.
Yeah. You can see that this is the forearm Ilizarov application for just let me see. She can do all movements with that, rotations and everything. And you can see that this is the initial surgeries and initial X-rays and plate application and non-union, you can see. And gradually that has dehiscence. This is after removal of the frame. And this is the final union.
So duration of the frame, sir?
Duration of the frame, usually they take about 9 months to 1 year.
Sir, position of application of the fixate, whether in flexion or extension, sir?
Which one?
Usually fixate at the proximal, near the elbow joint.
Earlier?
At the elbow joint, during the transverse wires, while passing the wires, you'll give the elbow in flexion or extension.
In
sir?
extension.
Okay.
In extension.
Okay.
Because most of the times the flexors are the giving problem. So if they are in extension, they don't give much problem afterwards. Usually I do it in extension.
Okay, sir.
This is the ROM after that.
Do you use any traction device while application of the frame, sir?
Locking?
Traction device or like your traction device, sir?
Traction device?
Yeah.
No.
Okay.
I don't use any traction device. Both the bones were settled with the same frame, with the 4 rings. 2 half rings, or 1 5/8 ring and 1 half ring, and 2 full rings.
So, sir, for the knowledge of the youngsters, how many wires per ring you apply in forearm, sir? What is the protocol for you?
Usually 2 wires per bone.
Right, sir. So,
2 wires per bone and 4 wires per ring. Because the same ring accommodates both the radius and also the ulna.
Exactly, sir. So we have 1 wire through radius and ulna and other wires through radius and ulna separately, right, sir?
Yeah. Yes.
Yeah. That is the key, sir. Yeah.
Okay.
Sir, can I share Srinivas's post-op radiograph and the clinical picture, sir?
Yeah. You can.
Just a minute, sir. So is my screen visible?
Yes, yes.
Sir.
But one thing, what I want to say is these X-rays are at the end. Is the beginning X-rays. I had to search because these are the X-rays which I have taken just before the fixator removal. The middle fragment, the fibular part, the wires are missing because I removed them. That is with the frame X-ray. And that is the 3-ring fixator and no ebony fixation actually, despite intra-articular nature. Still, there is a little bit shortening is there, really. There's still shortening is there, meaning about an inch shortening is there. It's not fully compensated for the limb length discrepancy.
Does anybody else have any questions to ask regarding this case or any of the other cases that have been presented so very eloquently by both our speakers?
Sir, maybe I have missed the talk. Can you know how long did you keep the brace, sir, after removal of the fixator?
I kept it for really 1 year. I kept the brace. The patient is quite active. The patient is quite active, pain-free, and is confident because we are not confident. The patient was so confident. He removed the fixator. He removed the brace after 1 year. After 1 year, I said it's better to keep it. He said, I'm pain-free. I'll remove it. He removed after 1 year. It's only a brace.
They lose the confidence after breaking only.
After
refracture. Not before that.
Yes.
We will be worrying, but the patient will be confident that he is not having any pain and nothing.
If he is pain-free means he will be confident.
Yeah.
Yes.
Karthik sir, this was the case. So it was a grade 3B tibia with metadiaphyseal dissociation that sir had initially treated with X-fix and later on went on to treat with a Ilizarov frame. And while doing that, he transported the fibula, causing a musculovascular tibiofibular synostosis to gain alignment and length, sir.
Sir, transport with wires or shanking, sir?
Fibular transport with 2 olivers.
Only 2 olivers.
2 olivers equidistant at proper position. Actually, one should be here and one should be here. Actually, sorry for not including those X-rays. Next time I can further, because this is in a follow-up phase. After 2 years, I have to present this again when the tibialization is perfect. This is in the midterm actually like that, because still if you see the X-ray, tibialization is not complete. It's about 60-70% maximum. 30% is pending. So at the time, I had to present it again.
Okay, sir.
So,
Sir, for the fibular transfer, did you use the plates and slotted rods?
Plates? What do you say? Hoda?
So for fibular transfer, you use the long plates and slotted rods or something else, sir?
Long plates. No. I didn't use that. I used differently. What you said is right. Long plate is needed, but I modified it. You can see that clinical picture. I used in a different way. I used a small arch. Arch. If you see the clinical photograph.
Akansha, can you please keep that clinical picture, frame construction?
Before that. 4. Yeah, this one I used. Hoda, Dr. Hoda. I used an arch which has 2 olive wires, and this is getting translated anteromedially. This is fixed here.
Right.
Long, as you said, that plate with long plate with extension of connecting rod that can be used in this.
So this looks like more innovative than plates, sir.
Maybe. That is called Ilizarov is versatile because everyone does in a different way.
When the right thing is not available, we become innovative.
Yeah, yes.
So, Novikov sir says that Ilizarov means possibilities.
Yeah. Lot of possibilities.
Options are there.
Your
It's a-
imagination is the limit.
Yes. Your
Exactly.
limitation of instrumentation and your imagination.
Your
Both.
imagination.
Both go.
Right, sir. Right, sir.
Sir, fixed time, sir.
That can be the theme of the next webinar, sir. That's a very well said statement.
Sir, fixed
Fixed
time.
Yeah.
Fixed
Fixed
time,
time
sir.
is really 1.5 year. 1.5 year. More.
Sir.
More.
Pin track infections.
More, but pin track infections now and then we'll be seeing that is a common thing. That's a pin track. Not it's a
As there is a
simple
big
form.
span, the chance of pin track infections are more. Na?
Yes. But usual pin track infections, not disastrous like osteomyelitis, all those pin track. The usual pin track infections were there and they were dealt. Most important thing is the patient, the amount of pain was so less when compared with corticotomy. That is the significant thing which I observed in the fibular transfer.
Does anybody else have any more questions to ask?
Sir, any experience of any of you on hemifibular transport, sir?
Hemifibular transport.
Linear corporate.
Hemifibular
Prasad,
transport.
sir?
No.
To split the fibula vertically and then transport, keeping one side.
No.
We have good reason and less chance of fracture, I think.
Yes.
So, sir.
Exactly.
But
No.
long time.
Hemifibular callostasis. That is called hemifibular callostasis. No, it seems to be more difficult. Actual fibular transport itself is a little bit tougher one. Hemifibular is still difficult.
We'll wait to
I'd
see
like
in your cases, Karthik.
Yes, sir.
You try.
In the after webinar.
Dr. Karthik, you try in future.
Sir.
Exactly. Very good.
I go for total transport of tibia rather than hemifibular transport. Because that gives like a sheet with the width of the fibula and the dia of the tibia. It is like a sheet. Sometimes sheets also will break easily. If it is not round, the round structure is more sturdier than a sheet structure.
Okay,
A sheet structure, there is every possibility of breakage.
In hemifibular, that fibular, half fibular transfer. Yes. It is like a
You
sheet.
can have a splinter. Yeah.
Okay, sir.
If there are no further questions, I think we can end this wonderful academic session tonight. Shamshul sir, would you please say something?
Yeah, thank you all, sir. Thank you, Akansha. Thank you, Prasad sir, Reddy sir, and everybody here. Thanks for all the delegates, and especially from other states like Pritish and Amir Bera sir, Barua sir. So this is a real motivation and learning example for all the young surgeons. They can ask so many questions. This is not possible in ASAMI Mega Mastercard webinars. So we request all the other young surgeons who just missed this session to attend the next session. And I also request other states, other zones to make such webinars so learning goes on. So thanks again, Akansha, for making of such a wonderful initiative. And this should be a prototype for others. So waiting eagerly for the next webinar from Telangana side, other sides. With this said, on behalf of ASAMI India and me and Rajat, I'd like to thank everybody. Good night and see you next week. Thank you.
Good night, sir. Thank you so much, sir. Thank you,
hello.
Prasad sir. Thank you, Srinivas sir. And I'd like to take a minute and thank my HOD when I was doing my senior residency, Dr. Ravindranath sir, who's there with us tonight. So thank you so much for all the inspiration right from the beginning of my training days to the stage that we have come today, and that we are conducting a webinar with you in attendance, sir. So thank you so much, everybody. And it's been a very inspiring and a great learning experience. And thank you, Vijay Bhaskar sir, for taking your time out from your busy schedule and coming down as well. And thank you, everybody from all over the country for joining in.
Thank you so much.
Thank you, Akansha. Thank you. Hello. Hello.
Sir, tell me, sir.
Akansha, I congratulate you for your inspiration, aspiration, and for the dynamic way you have conducted the webinar and also forming the group in such a shorter time and coining the theme like learn today and lead tomorrow. Basics, back to basics. Everything is good and
from your side. I congratulate you and my wishes to you.
Thank you so much, sir. Thank you very much, sir. Looking forward to learning more.
Congratulations, Dr. Akansha, for the short this thing notice, and then you have done it well. Congrats.
Thank you, sir. Thank you to both of you, and thank you, Shamshul sir, for being the brainchild behind the Budding Ilizarov Surgeon Forum. Most of all.
Thank you, Prasad. Thanks a lot. Thanks a lot. I request everybody who are not member of ASAMI to become a member. Yeah.
Thank you, Hoda. Thank you.
Thank you, sir.
Bye.
Thank you, Hoda, for being here and sparing your valuable time.
Thank you, sir.
Thank you, sir. Thank you very much, sir. Good night, sir. Thank you,
Thank you
everybody,
all
for
the
coming.
participants. Thank you all the participants who are there. And
Yeah.
Vijay Bhaskar, sir.
Yeah.
Yes, sir. Yes.
Thank
Thank
you.
you
And
so
good
much,
to
sir.
all.
Good night, sir. Bye, sir.
Right. Bye.
Rishi, we can stop the live stream. Rishi, we can stop the live stream from OrthoTV. Rishi, are you there? Okay, you must be busy. Okay, sir. Good night, sir.